the slides. I want to welcome everybody to the workshop on educational applications. So the format that we're thinking of today that would be ideal is we have very brief descriptions of each person's background and why we're here to help lead you through this process of brainstorming ideas that you might want to take in with your collaborators for funding. And after the presentations, we'll have a brief discussion sort of among us and with you. So I encourage everybody to kind of move up and be part of this discussion because our size is sufficient so that we can make this a conversation. And then we'll break everyone up into groups based on interest, and we can go through that template of just playing around and thinking about if I were to generate a eventually fundable proposal, what are some questions that I would want to ask? And we have experts, including our statistical experts, to circulate and help think through these sort of early stages of what a project might look like. So again, that template is in the form of a Qualtrics survey on the website. And this is useful for two reasons. It's useful for us to be able to provide you back with a deliverable of what you talked about. And so we can say, it's like, here's the folks that came to the workshop, and here are some questions that we were able to answer for them. Any questions about that format? Okay, so why don't we go from slides to the rest of us, because I did not bring any slides to discuss. So what it would be great if you could just represent, like, this is our background, this is what we're interested in talking about, and then we'll follow from you.
Okay. Our background, we are interdisciplinary. I am associate professor at design and environmental analysis. My background from architecture, interior design, human-computer interaction, focusing on virtual reality and usability of virtual reality applications in design communication. And Dr. Jae-young Shin is a medical doctor and PhD in public health. We're going to talk about briefly how we can create comfortable VR experience for our context for patient education. And then,
yeah, thank you for the introduction. So my name is Jae-young and I'm from Seoul, Korea. So I think there is already a very good teamwork between physicians and VR researchers at Wired Korea. So I just want to briefly introduce a process, how we started our research together, with Soyeon, and developed it and got some research fund in Korea. Actually, there are 5 steps for us in the project. The first one is building a great teamwork. Okay. So one day, Soyeon's family and my family had lunch together in Ithaca, and my wife, she's a nurse, and she suddenly suggested some nice idea which can be implemented in hospitals using VR. But unfortunately, I didn't know how to design 3D environment in hospital and how it would be similar to the real environment in hospital, because I'm not expert in that area. But Soyeon is a great, excellent expert in making a digital environment. So we decided to start some project together. So the second one is targeting disease for adapting virtual reality. So it means, since we consider very practical VR explanation for patients, I asked many of my colleagues, physicians or surgeons in other departments, and found their needs to have an extra modality to to educate patients. Then we picked 2 diseases. First one is breast cancer, and the second one is lung cancer. So in terms of breast cancer, the most prevalent age of breast cancer in Korea is between 30 and 50s in Korea, so it's totally different from the US epidemiology. So since they are relatively young, and so we want to evaluate because they are relatively familiar with digital environments like the virtual reality. The second one, lung cancer, we wanted to examine whether results from lung cancer would be similar to the breast cancer pilot study. So because patients of lung cancer are older than breast cancer patients, and more than 50% of lung cancer patients are male, so we may find some different outcomes according to the different population. So the third step is designing pilot studies here. So this is my own area, but we had to talk about this a lot for, I think, more than 6 months, because we had to consider how we can estimate outcomes from clinical aspect, managerial aspect, and patient experience. So even though I'm physician, flows of explanation are totally different based on disease and departments. So we had to share all the process together, and we also reviewed a lot of papers uh, because we had to decide which measures we will include in the study. So, for example, to make a little difference from previous research, we made a decision to collect saliva because we can detect some stress hormone in saliva, so something like that. So the first step is making design environment, mostly done by Soyeon. However, our experiment sites are in Korea, so she's in Ithaca, so it was not able to do something together at the same time. But she gave a lot of good instruction how we have to take a 360-degree video shot and how physicians act. Make a pose during shooting like that. So we had a regular Skype meeting once a week. So I believe it is really helpful for us to uh, make progress shortly. So after she made some excellent 3D images, physicians and I gave a lot of feedback, and we finally can get a wonderful digital environment. The final step is collecting patients and give a feedback to all our researchers during experiment. Since we are also preparing other projects, so some ongoing feedback from patients are really helpful us to make a better plan, making a better research proposal. So I believe that the teamwork is based on 5 steps according to my experience. And before I let up my presentation, so I highlight the importance of teamwork again. Nobody can know all the things from making 3D environment to evaluating outcomes together. So it's very important to share our own expertise and knowledge and share future research plan together. We already have had some funds and also have a plan to submit another research fund, which is available for researchers between the US and Korea. And this great teamwork help increasing chance to have another one. So I'm very pleasant to have talk here, and we are very happy to have a future chance with other research teams at Cornell or at some other place. And we are very happy to answer all some detailed questions. So happy to share our experience. Thank you.
Hi. So I have a different side of the kind of emphasis here. So we all know virtual reality, the key word is presence, being there, right? So we want people to be there comfortably and make the benefit should maximize when they have comfortable experience. So how do we bring them there, actually, virtual environment comfortably, and they're feeling comfortable? So there are certain important things to consider. User characteristics, we always need to emphasize user characteristics. So when people are interacting or in the virtual environment, we need to consider gender because they tend to have different perception and experience and the age and prior experience that's tied to age to some extent, and processing style, how different people process visual information and spatial information differently. And the items can go on in the category. And the technological characteristics, visual quality matters, and also the speed, graphic quality, color depth, and resolution, and input devices. There are many things we have to consider in that category. And then environmental characteristics. What kind of environment do we show? And how we shoot the environment or create this virtual environment from what visual perspective. That I'm going to talk more about. And then other considerations, duration of stay, how long we have to, we can have the patient or viewer to stay. What's the maximum time or degree of interaction? How much interaction we should provide? It should be entertaining, enjoyable, but at the same time, we don't want to cause nausea. There are no side effects in virtual environment. So there are 3 different types I can name for immersive environment: 360 panoramic photos, still shots, or videos. You are familiar with the YouTube roller coaster simulations. They're all video recorded using 360 cameras. It can be still shots with a higher color depth, but there's no dynamic parts in those. Lastly, 3D computer-generated environment. The great thing about this 3D generated, computer-generated environment, you can create the environment. Since it's a geometry, you can actually have the viewer walk around the space and look around the space and touch things, although it's virtually. So these are main types. And they come with the pros and cons. 360 photos and videos, as long as you have the space ready, then taking pictures using 360 camera, they are relatively, it's a relatively simpler. Cons, you really need actual environment is ready and applicable. But also you have limited interaction. You can add hotspots, but you cannot make things animated in there unless you do go through post-production steps. And 3D computer-generated environment, on the other hand, pros, you can virtually add anything, everything. Avatars, animated objects, animation, let's say, triggered by proximity sensor, which means if you go closer to a certain area, then lights can start, and music can start, and door can open, or if you touch something, things can change and happen. Yeah, any magic can happen too. Cons, you need more specialized skill to build 3D environment and the programming skills. And also for computers, you really need a very expensive gamers computers to do this real-time renderings with high quality visuals. Also, they are known to have more, give more negative effects because you have more movement there. So I want to emphasize when you have more dynamic quality in your VR environment, more likely you give negative, your patient and viewers have negative impacts. But if they are in that environment short time, I think less than 10, 15 minutes, then eye strain would not be a problem and less likely to cause dizziness. But if you have a lot of moving parts in there, again, even a few seconds can make a big difference. Some extreme environments like riding simulation that bike riding simulation I had, you are moving forward and all the cars are going backward, coming to, from the opposite side, and buildings are, along with the buses, cars, they are moving to the same direction and different, the buildings are staying, but you are moving forward. So there are a lot of dynamic movements and you can get sick in 10 seconds, So that's how you determine what kind of environment to do. So how do we know? Until you actually have a person or yourself experience the virtual environment, it's really hard to predict. The idea for bike riding simulation sounded perfect, but I realized on the first day of data collection, I mean, that's a pilot data collection to understand user experience. I was the first person, and I decided not to go ahead using HMD because it was so extremely uncomfortable. So we need to do user testing, whenever it's ready, and then over and over and over until everybody try the virtual environment, say, this is comfortable enough and there's nothing to worry about. And it was, and then how do you understand, how do we know that's the experience? Then you need to think aloud, self-report, and then more extreme, it's more advanced trick. You can do biofeedback analysis. This is actually research opportunity. For application, you have to do user testing to avoid any problem, to ensure the optimal user experience before, during, after being there. But this is our chance as researchers to have a quality research outcome. That's my part. Thank you.
Thank you so much. So that was a great overview of a number of considerations to take into account when designing these educational experiences. I wanted to move over a little bit and talk about more traditional education applications, especially in simulation, and talk about the opportunity to build on existing training applications. So taking what you said about testing environments and looking for metrics to tell us when students are actually learning, and talking about building on environments that have been tested in some aspects, and thinking about how we can add a virtual or augmented or mixed reality component to build on those. So I'm going to say a little tiny bit about my background. Before I've been working in a research capacity and virtual reality for about 10 years. But before that, I worked as a biomedical modeler. So I was interested in creating models for education, for surgical education. And that kind of led me into the virtual space as I moved into working with digital models and thinking about the aspects of people interacting with those models in a virtual space. But what that left me with is a sort of respect for how much we can bring from haptic feedback, and how you can combine physical models and virtual models to have a really informative, immersive experience. So do you want to comment on that, Brian, or comment on where you're coming from as someone interested in training and using virtual environments?
Sure. Just for a little bit of my background. So I'm a clinician here at Weill Cornell. I'm one of the hospitalists working in internal medicine. And so one of my main focuses, apart from clinical medicine, is working with undergraduate medical education. Specifically, I like working, or I'm trying to do more work rather, with the pre-clerkship students. So these are usually first and second year students before they've actually gone onto the wards and started their clinical clerkships in medicine or surgery, what have you. And so at that time, traditionally, you've done a lot of basic science. You learn about like backgrounds of the cell, metabolism, genetics, things like that. And then you move on to traditionally, like, here's the normal body, and then here's all the ways it goes wrong, and here's what we can do about it. But I think it's a bit of a, you can see the door, but it takes another step to learn how to open the door and to walk through it. Because even though you can read any book that you want and be like, okay, let's talk about a myocardial infarction, a heart attack. Great, you know all the pathophysiology behind it, but actually treating one, like if you tried that just having read the book, it's probably not going to go very well. And so one thing that I see simulation being is a way to kind of bridge that basic into the clinical realm as well. And so we already do a little bit of simulation in that like pre-clerkship curriculum. But what I'm interested in doing is trying to apply concepts of not only standardized patients and like mannequin-based simulation, but virtual reality as well, and trying to see, all right, we have these other two simulation modalities. What can we use virtual reality for to build on top of that? I talked a little bit yesterday that I think virtual reality for anatomy and especially like anatomic modeling can be a real benefit, not just for actual medical students, but even for kind of higher up people like myself. If I need to do a procedure, if I want to like review the anatomy of a particular joint, it could be great to see like a floating 3D model of that. And especially if I could manipulate it. I saw a little bit yesterday with the College of Veterinary Medicine or with Ali and Julie that, if like just even seeing that, like, all right, here's the horse leg and it bends, great. Like if I could do that with like a human knee, for example, and be like, okay, so here are the ligaments that I'm worried about and like why this person is coming in with knee pain, for example. I could just go on talking about that, but I see enough knee pain as it is. The other thing I think virtual reality can do is there are certain things that we can't simulate very well. And so our work that we're doing right now, we're kind of in early phases of it, but again, just to reiterate, is primarily right now looking at the opioid crisis. So kind of like what Ji Yang was saying is finding, particular diseases that you might be able to intervene on. The opioid crisis is a massive public health, just doonboggle, I guess. Boondoggle. Doonboggle, what? Yeah, it does, right?
Sounds appropriate.
It's a cluster. Let's go with that. And suffice it to say that we know, and we have good evidence showing that providers specifically have a stigma against people who have substance use disorders. And so what we're looking at right now is using virtual reality or augmented reality potentially as a way to kind of bootstrap empathy for these students to try to like show them, here are patients who you're dealing with. Kind of one idea we had was to put them in the body of someone who has like an opioid use disorder and kind of get them to experience in some small way, not too particularly uncomfortable for them, but to get the idea like these patients, they have a disease, and what they're doing is they're trying to treat their own disease, but oftentimes that can lead to a lot of complications down the line, both physically, emotionally, psychosocially. And so I think virtual reality might be one way to do that. And the other thing that we're looking at is for physical therapy too. So our students, they do like an interprofessional day where they'll go around with physical therapy and kind of see them work with patients. But a big part of physical therapy is seeing how patients do at home, seeing what's possible at home and how safe things are there too. So I have a lot of geriatric patients I end up taking care of. And as I mentioned yesterday, there are a lot of things at home that can be potentially very dangerous to geriatric patients, and being able to look out for those proactively and see them. So as a provider, knowing like here are the things that a geriatric patient will look for, especially even in New York City. Like I'm from Iowa originally, so we didn't have like a lot of stairs in general, like a one-story house, right, and a basement, right? But yeah, it was a basement. Here, it's like when I came, people were talking about walk-ups. I'm like, the hell's a walk-up? And they're like, oh, there's, they have to walk up 4 floors to get there. I'm like, they're 80. And they're like, yeah, they can do it. And I'm like, can they really? Wow, that's impressive. But some people can't. And being able to know like those particular physical limitations and the intricacies of the environment that you're practicing in is really key. And so I think one thing that we could do with VR would be to simulate those different environments. You could do like kind of what we imagined is, you're walking around like a simulated apartment and you can pick out like, oh, this could be a problem here, or go to the bathroom. Oh, they don't have like any grip tape, or they don't have like arm bars to hold on to, because, if they fall and they're not found for a couple days, like broken hip, intracranial hemorrhage, that could be it. And so trying to be a little more proactive, preventative, even with some of that. So I think those are a couple areas that we're working on actively right now to introduce VR and layer it on top of the curriculum that we already have.
So thanks. So I asked Walter, because he is the one with the longest experience in virtual reality, to overview, and I want to ask him 2 particular things. First of all, if you could give us a sense of where you're, for those who've missed maybe the first day, to get a sense of your deep background in virtual reality, and also to talk about where people can go to find resources of what's already been created, because some of the things we've been talking about, so for vision, we know that there have been simulations looking at simulating vision and simulating the experience of having schizophrenia. So talking about like where are some sort of research resources that you could go to look for what we can build on
and go from there. And then I would like to ask, after Walter's spoken, that we all sort of pull together, because I think there's enough people that it would be productive for everyone to mention their interest and why they're here. So I know from looking at some of you what your background is, but if we're going to be working on groups and specific projects, it would be nice for us all to have a sense of where we're coming from.
Okay, well, thanks for the introduction, Andrea. And I'm so glad you didn't introduce me the way I was introduced 2 days ago. I was introduced as an OG, and I didn't know if that meant original gangster or old guy. And I prefer Vanguard. It would be my preferred nomenclature. Well, and in terms of resources, gee, there's so many. I made, and I will go over them, but I made a few points I wanted to throw on top of the excellent presentations we've heard so far. I think a lot of the value of education training in the medical arena can be boiled down to building situational confidence. There's a lot of knowledge, of course, that we can get, book knowledge, but Chris, it was you who said OG, right? Yeah, that's right. Okay, all right. Yeah, right, a few days ago. Anyhow, and I think one of the things that is being built right now as a capacity that we can bring into our training environments is the capacity to dynamically adjust the learning environment to the learning style of the user. And I think we can do that by paying attention to gaze direction, to if it's a skill-based learning that involves a procedure, we can do the timing. But heretofore, we have not had the capacity to objectively measure progress based on an individual's learning style and dynamically change the environment. So I think that that's really going to be the big revolution, is to be able to build a feedback loop, dynamically change the pedagogy for the individual based on their learning style. And I think, of course, being able to do offline learning and learn at your own time and availability. One of the limitations of the amazing simulation centers that we've had is that people often had to travel from a long distance, be there, take some time off from work to do that. But with the layer of technology that we have right now, people can learn and refer something as needed. So if it's a particular surgical skill or how to use a particular piece of equipment that maybe you were trained in 3 years ago, or maybe you haven't had adequate training in, but you'd really like to be good at before you go into the operating room, we can do that sort of on demand to some extent, to a better extent. I guess I think the other thing that's really exciting, and you mentioned this in your presentation, Brian, is the ability to do the perspective taking of seeing what it's like to address people who are going through the patient experience, to be able to go out into their home environment and see what the constraints are. And also, I think we're getting better at just basing our pedagogy on the reality of the patient experience. So we've always sort of had a helicopter view of what the patient's experience is and our own theories about that, but we can now see what the patient is seeing. We can capture their experience starting in the parking lot, and we can use that as a way to refine our training so that we can better meet the patients where they are. So I'm excited about the affordances that today's technology are bringing to us. In terms of where the resources are to get up to speed about what's going on, it's difficult because there's a large number of academic arenas that are building up their own implementations of this, and there's no one spot where they get together to compare notes. There are several conferences specific on medical applications of VR, but they really span the gambit. We really need to have something that's specific to education. Because right now it's sort of distributed. There's simulation conferences, there's we probably all go to different conferences in our specialty area, and things are popping up in the middle of those conferences. I do think the conference in Nashville and the conference in Cedars-Sinai, and there's postcards describing at least the Nashville conference out near where the coffee is. Those are good starting points, but again, it's not really specific to education. Chris, do you have where would people go from your vantage point to learn more about what's going on in education in the medical arena?
I think that is a challenge. feel like we can help that along with our platform, but I think it's our collaboration. We can only pull what we know, and others can share as well. What kind of putting a database together? Because I think there are a lot of these competitive, not really competitive, but they're things that individual research and academic centers and hospitals and groups are doing on their own, and developers, and some of them are just been done elsewhere, and trying to reinvent the wheel. We need to modify.
One resource I'd like to point you to if you're interested in surgical skill training, but I think it also could be extended out to other training. There's a company called Arama VR, which has a pretty good multi-user surgical skill training system, but they provide the SDK at no cost to anyone who'd like it. And if you're going to commercialize based on their SDK, they'd like to talk to you, but if you're doing research or education or development, it's available at no cost. And I love the fact that it's multi-user, so you can have a clinician in one country meet with a clinician in another country and look at a virtual patient and dynamically talk about how to do the surgical procedure. But it doesn't have to just be surgical procedures. It could be built out to really any procedural based process.
I have it demoing there, so if anyone wants to try it out. I don't have the two or more person system to connect collaboration there, but
Oh, that's great. And I think their SDK really could be generalized beyond to almost any procedure-based process. I guess in terms of what I think is a problem is what platform are we going to use? There's so many wonderful VR technologies. There is sort of a backbone of Unity that many of the groups are developing content and are using. I assume you're Unity-based, correct? But beyond that, people develop on the HTC, people developed on the Quest, and I think that's a problem for an educational institution is they're trying to decide, okay, if we're going to buy 50 of these, which platform do we choose?
Yep.
And how are you addressing that, for example?
Still working on that. I think we actually just had a meeting since Cornell is kind of an Apple campus. We actually just had a meeting with Apple. They have a new kit, AR Kit 3, I think it's called, that's coming out. And so we just had a meeting with them to try to determine, could this be possible? I've been meeting with Joanne a little bit, but I think that's one of the big questions I personally have is, okay, so there's HTC, there's the Quest, and Apple, if you do more AR, like, this is going to be a pretty big cost. I don't want it to just,
Evaporate.
Yeah, exactly.
Yeah. Well, and it's not, and for example, even though Chris mentioned earlier that Google's stepping away from their VR applications, they're still going very deep into AR. So when you talk to Apple, don't forget about Google and Magic Leap. I mean, it doesn't get any easier as we move from VR to AR. There's still too many options really to consider. On the other hand, that's not the hard part. Sure, we may have some sunk costs that we'll have to walk away from in 5 years, but the hard part is coming up with the curriculum. It's not just the same as taking what we used to do with textbooks and snapping it onto virtual reality. We have to really rethink how we train people, and that will be portable from platform to platform.
Do you see the headset evolve into a place where it's just like a monitor, taken by any sort of monitor, either HDMI or digital or any other connector, and even at the point you don't need a specific
I do. The question was, do we see things evolving so that much like I can get into an automobile and just drive it away, I don't need to know how that there's enough of a commonality between the different platforms and portability of the content between it. I do see that, and I also see some of these shared virtual world platforms being a venue to get started, and those are not just cross-platform, they're transmedia. So you can have a virtual world that you meet people in a fully immersive environment, but you can also see it on your cell phone or your tablet or your monitor. So I think in the near future, hopefully, things will be transmedia and trans-platform. But Chris, you're closer to this than I am. What are your thoughts about that?
So at the end of the day, the headset is just a monitor, right? I mean, just simplifying it, it's a way to project and stimulate the visual cortex. Of course, the fact that it's 3-dimensional and that you have hand tracking and head tracking and down the line body tracking. You have eye tracking. Those make it more than just a monitor. But yeah, I mean, I think there's only gonna be 2 or 3 platforms at the end of the day. So and I think there's going to have to be some cross compatibility in transmedia, as Walter's saying. I'm not a hardware guy, so I can't really prognosticate about the future. I can speculate based on a little bit what I know, but they don't tell me very much. So yeah.
I will comment. Oh, sorry.
Go ahead.
I would say that in our lab, we try to stick closely to the consumer hardware because we are interested in being able to roll it out to collaborators at different institutions, but we've appreciated headsets that are sort of open to being worked on with different platforms. So we use both Oculus and Vive because most people can get their hands on one or the other, and because we can develop in Unity or Unreal for both of those platforms. And so I think that even though there is this tendency to be pushed to commit, I think that is actually reducing its accessibility. As Walter said, if you focus on building for a particular hardware device or even building using a specific modality, then you are limiting your ability to expand and grow. So if you think, what is my curriculum? What am I teaching? And then you can pop tools in and out as they evolve because they're evolving so quickly.
I think that's a good point, and I want to make 2 more observations. Number one is, if I were choosing a hardware system to work on today, again, depending on the situation, I might be more inclined to go with HTC or HP or almost anyone other than Oculus, even though they seem to have a market share. And I'll tell you the reason for that. In the medical arena, I'm not sure people are going to trust Facebook. You might put a lot of effort into developing a great assessment, a great intervention, or a great training system. And again, I think those training systems will involve collecting a lot of data from the user, so it can be dynamically changed. But if the business model is to resell the data that's collected from the platform, I think that's a problem. So nothing against the hardware, but I worry about the business model of that company.
So that's a specific point about privacy that we need to keep in mind too. So the question of, especially when you have inside-out tracking or when you are incorporating scanning to generate avatars, that's an incredibly valuable tool using eye tracking data to drive content, but including in an educational setting and even more in a clinical setting, knowing where those data are going to go is super important.
Just as an interesting aside to that, we talked with neuroimaging about, and even just any kind of criminal data, scraping or anonymizing the data. And there's a researcher at Binghamton until recently who they got scooped up by Google, who had developed a way to identify you uniquely based on your EEG data. And
Even if it's anonymized. Yeah.
right, so
Yeah.
that's the problem. Like if you collect enough data about someone, then you can anonymize it because it's so indelibly you.
Right. Well, you can anonymize it now, and in 3 years, somebody will come along and point out how they de-anonymized it.
yeah.
So,
I had a question to your point about the translation of existing curriculum to adapt to the resources. So, you raised the point about how VR is a natural fit in terms of simulation, experiential based learning. How do you translate didactic learning into VR, or what are the ways to take advantage of VR so that didactic learning is enhanced?
So I guess the first thing that comes to mind actually, where was it? It was the IMSH, so the Society for Simulation and Healthcare conference that they do every January. The one this past year had, there's a group in Peoria, Illinois called Jump Simulation, and they had a program, and oh gosh, I'll work on remembering the exact name of it.
I think maybe we can share notes
Yeah.
after the workshop is over,
Mhm.
because we've had some really good resources mentioned already.
Yeah. What they did for that is they actually thought very much the same way: is how can we take didactic learning and make it somewhat more engaging, interactive? What they did is I think they took a CDC. It was like an opioid prescribing course or something, and it was an hour-long course, didactics, just like watching slides and such. And they were able to compress it down to about like 12 minutes or so. And what they did is they would have an instructor who would go through the slides, go through the curriculum, and the instructor would actually have glasses on that would be tracked by the recording software. And then in the end, after they had recorded that, they would put you in the virtual space. You could see, actually, because of the glasses being tracked, where the instructor was looking as they went through different slides. But the nice thing was you could actually pause the simulation. You could pull up the slides yourself and look at them. They were also showed that this was applicable for looking at like CT scans, or if you had like a cardiac MRI and someone was going over cardiac anatomy, as they're going through these particular points and pointing them out, they had a pointer where you could track and see what they were pointing as well. You could just pause the simulation, actually grab onto that particular MRI, blow it up, and then be able to see, okay, like take your time to look at it. So it actually, in that way, made it a lot more user focused in that regard. Like, you don't have to sit there and just wait for them to click through to the slide and then boom, they've gone forward before you have a chance to really absorb it. You can learn at your own pace and learn at your own level. So if you need to take a little bit more time, fine. But they found that being able to compress it into something a lot more interactive did shorten the time for the didactic. I will work on the name of that program.
And I think what we're training for is going to be very different in the next generation. It's no longer as important to memorize things or even remember things, because information is so readily available. It's more under having the soft skills, the interpersonal skills, the ability to have self-confidence in yourself, know what your limits are. There's so many different things to learn than lists. And so that, I think that will dramatically change that form of learning. I think the other thing that we can and will do is leverage our colleagues who are in the gaming arena. Now that we have a platform that involves computer graphics, computer generation, they've spent decades and billions of dollars understanding how to make engagement fun. And so if we want to make education more fun, more engaging, and leverage neuroplasticity, which is driven by reward systems, then we should look to the gaming community for, I don't want to say the term gamification, so I won't, but I think we should look towards how to leverage their techniques to up our game in a dynamic way.
So, because of my esteem, I forgive that that pun. I wanted to add one more thing, which is the idea that in a virtual environment, the concept of see one, do one, it changes into see one 100 times if necessary. So you do have the opportunity to relive experiences, either what your teacher did in a virtual environment, or if you have built a teaching example, then you can think about it not just that you're going through the recorded event, but that you have the opportunity to walk around and say, well, I've looked at it from sort of the classic viewpoint where I'm looking over the surgeon's shoulder, or I'm standing down by the feet of the patient. But if it's a recording, then you can really, forgive me, but you can really get up there and investigate from different angles, because and you can do that individually. So you're not saying stop the experience, I need to get a closer look at what's going on. You have the opportunity to do that at your home at 2 a.m. when you're confused about some aspect of the procedure. That is something that can be built into these learning opportunities. So that's exciting. Yeah.
In the IC when
So that's
I think it's also worth noting that everybody who is connected to this academic association or associated institutions has the ability to go to many of the companies that are trying to develop this and say, give it to me. And maybe go to some of the technology companies and say, please loan us or provide us with some equipment, because we're serious about this. Because you're in a position to validate and extend and develop and create and design. And the startups that are out there that are trying to get into this arena need you. And so I think it's really important to realize that you're in a strong position in terms of attracting collaboration.
Are there other questions For the panel now, or shall we, my next recommendation would be, if you've gone through your points, okay. My recommendation would be, if there are general questions, we could talk through some more general questions, or given the size of the group, I think it might be useful for people to say what they're interested in, so we could group up to talk about more specific applications. Are there general questions that we can present to the panel?
So I am a biostatistician, but also an educator in biostatistics, obviously. And we have been doing a lot of online teaching and have many different reactions to that. I'm curious about your medical students. How do they, do you have feedback from them? How do they feel about virtual reality education in general? Because we talk about user testing, user feedback all the time, but I'm curious if you have any data on how they feel about this and whether it's changing actually.
I think, sorry, I think from the medical student perspective, I think it's a little bit of a trade-off, unfortunately, because I think there is a certain amount of engagement that you can get in the classroom, like being able to ask questions of the lecturer during or after. At the same time, I think the students really appreciate being able to do something at their own pace, being able to like stop, rewind. Like even like when I was in medical school, however many years ago, it was 10, that's not that long. When I was in med school, all of our lectures were recorded. And so oftentimes what we could do is if we didn't go to lecture, we could just watch back the video. And the nice thing was we could watch it at like 1.5x or 2x if you were crazy. And so you could turn an hour lecture into 25 minutes and save a little bit of time for yourself, which was actually pretty nice. I think what we're seeing, especially with concepts like the flipped classroom, the idea that if the students are going to come in and they're going to be working like in an actual space in like the medical college, for example, that we want them to be as engaged as possible. And I think we're seeing that lecture isn't the best way to do that. If we can run them through simulations or give them the opportunity to work in like collaborative groups, either in like problem-based learning or something that's a little more like, let's get up out of the table and like work on something or go see patients on the wards. I think that's, the students are starting to see that's a better use of their time when they can just go back, they can watch a lecture that for them is going to be roughly the same experience. Plus, again, they can like start and stop it as they please. So I think it depends on what you put online. I don't think like putting up a slide set online and a lecture, fine. But putting up like problem-based learning sessions and taking them homework, I don't know how effective that is. I think like Dr. Greenleaf said, trying to kind of alter how we approach the curriculum and recognize that putting things online can be beneficial for students to go at their own pace. But I think there are some things that you certainly benefit from having like a live teamwork focused activity, whether it's seeing patients on the wards, doing physical exam, or running through simulations in that way.
I can speak a little bit about what you asked because I teach the first year and I do both lectures, PBL, and histology labs. The attendance lecture after the first couple of weeks drops to because they are recorded. I mean, 40%. I mean, depends on the classes. But this year class is probably less than 40% because there is no point in sitting in class. Although there are advantages like asking questions, there are not much point sitting in class. The PBL is mandatory.
Yep.
So everybody goes there.
Problem-based
learning,
learning.
sorry.
Basically they like,
so
they run through
it's
cases.
we run through cases. It's mandatory, so it's not clear what the attendance would be if it wasn't mandatory. But then problem-based learning, everybody comes. Some labs, like histology labs and small group sessions, the attendance drops a little bit during the year because it depends also what kind of testing you do at the end. Because if all you test is recognized on an image which one is the liver and which one is the stomach, then there is really no need, there is not that much need to go to the lab, honestly. Although you gain much more if you go to the lab because it can be put more in a context of what the relevance of the liver structure for liver pathology. So there is definitely an augmentation. That's why a lot of people still go. But depending how you testing, then there is a little bit less or more advantage in participating in different modalities of teaching.
And I think one thing to piggyback off that, and it's actually a question, I'm not sure, you're talking about like the EPOM curriculum in
Yeah.
histology. So do you use virtual microscopy or are you using actual slides?
Virtual. No,
You're
actually,
virtual.
I designed the virtual microscope.
There we go. Yeah.
Yeah,
So in that case, they're not actually looking at microscopes. They've got like computer slides and they can pull them up. So they're very representative slides. It's like, here's a great look
well,
at like
so
liver
what, with this one,
architecture.
we had a lot of debate about abolishing microscope. The slides that we have is really virtual microscopy, so you can zoom in, zoom out.
Yeah.
So it's not much different than sitting in a microscope, except that you can. I mean, there are little things like phase contrast or closing the diaphragm, so
Right.
you can see different planes. But it's very similar. Yeah. But then, I mean, since it's on the website,
Yeah.
then you can do it at home. There is no really the dramatic need to come to the class.
And is that overall? So overall, it gives them more time to spend in the lab context. Do you feel like, or do you feel like there's a loss?
Well, I mean, that's I sometimes look at the for lectures. It doesn't seem to be a correlation between the performance in the tests and if you are to the lecture or not. For the labs, I check the groups because I mean, especially before, because when I was totally responsible, and the people that show up in labs do a little bit better.
Yeah.
Now the question is, they do better because they're more interested and that's why they show up to the lab, or do they do better because they actually came to the lab? And it's difficult to do testing there because you cannot say, okay, you come to the lab, you don't come to the lab,
Right.
and we'll see who does better. So since it's a self-selected group, it's a little difficult to get accurate numbers. But in general, but interactivity is the key. So people come to the PBL and they like it. No, to go to a lecture, honestly, I mean,
Especially if it's at very early in the morning.
yeah,
Yeah, no, 8 a.m. lectures are the worst.
it's 8 o'clock. Yeah,
Yeah,
I mean, when I was in when I went to medical school, I walked 10 miles in the snow to go to lecture. Because, but just because there was no videos, because otherwise I would have stayed home and not walk in the snow 10 miles without shoes.
Oh, it's a beautiful summary. Are there other questions for the panel?
Student body is changing, so it's really useful to collect very simple feedback from them each semester and actually learn how we can optimize the experience from their perspective. So I just wanted to make that point.
I will say, and we have done some work on education, not in a medical context. And one thing that we consistently get is whether or not they learn better, they say that they learn better in virtual environments. And so on the one hand, it's like, well, this is not our ultimate goal is not for you to be entertained. On the other hand, if you are entertained, then we have a better chance of getting you back and getting you to work more in that environment. So I think that's do they like it? And then do they learn from it if they like it? Yeah. Yeah.
Just an auxiliary question to that is, do they learn more effectively from the virtual environment? But then like an auxiliary question is, do they learn as well from non-virtual curriculum later on? Because that would be the one concern I would think with, for example, virtual microscopy. Do they atrophy some of their skills in actually using a microscope to find optimal contrast if maybe they wouldn't actually be in that situation because typically there would be a pathologist doing that work. But
the thing is also, I think it's for medical students, I think it's also important to teach of what they will encounter in the practice. And now histology and pathology, histology, which is a precursor to pathology is mostly going to electronic microscope. A virtual microscope, basically. So there is a scan, the slide is scan, and then they look at there. So teaching the fine point of closing the diaphragm and focusing on different planes, I think although I love it, but I think it's a little bit of it's not very useful because that's not what they're gonna see when they are pathologists. I mean, some pathologists still do it. I mean, but the movement is definitely going there. There's automatic scanning and then using artificial intelligence to look at the slide actually. So I think visual microscopy prepares them better.
Just to, as a final point to that, I think there's also enough variety in different medical education programs, different medical schools, even residencies also, that you can kind of pick out a residency based on what your own interests are. I did medical school at Duke, and when we came up here, I did residency at Columbia, actually. And one reason I picked it was because it seemed like it was going to be a pretty hard kind of down in the trenches residency where I would learn how to do everything, even if I wouldn't have to do it later. But I liked the idea of knowing that I could, get an arterial blood gas on a patient quickly if I needed. I did a lot of them. When I actually moved over here to Cornell to start as an attending, one of my colleagues who started out in the same year, she had never done an ABG, and she had been an attending for 3 years previously, and then had gone to residency in, I think, Kentucky. And she said, no, our respiratory therapist had always done it. And I was like, I've done like probably 60 of them. Like I feel very comfortable doing one myself. She never had, but she was still a perfectly fine attending. It was just kind of like what she wanted to do. Now I haven't done one for probably a year now, but it's nice to know that I still kind of have that skill in the back pocket. So some people may want to say like, okay, I know how to use a microscope and I can look at it just at its base value. But others may say, you know what, that's not what my job's going to be. And there are different residencies available for that. There's going to be different focuses depending.
So I know that you had a comment, and did you have a comment along this line as well?
Yes. So I have a comment and a question. My colleague here and I are both first-year medical students. We're actually going through the EPUM curriculum now, so it's been interesting to hear like the perspective of our educators, kind of like talking about things that we're going through now.
What's your perspective on their perspective?
I'm curious.
So I'm a class goer. We're both class goers, actually.
All right.
And we think we get something out of the actually being there in lecture that is different from like watching it online.
Mm-hmm.
But I've definitely used both. And I don't think that one should be replaced by the other, but that's just my personal opinion. I think it's like good to have options. Like for me, the recordings are good for if I just like can't be in class, or it's good to like have an option where if I need to schedule my time on a particular day to go do something else, then I can sit back at home and watch the lecture. But I think that, and this maybe applies to virtual reality in general, that it's not a replacement for the real life experience and that it's there as a tool to help. About the microscopes thing, I thought it was interesting that Dr. Fortes, you mentioned that people do better on the quizzes when they go to the labs, even though, yeah, with a grain of salt, yeah.
I cannot say that it's because they go to the lab, or they go to the lab because they're more interested.
It's not randomized.
Yeah, it's not randomized because
there's definitely some bias there.
Key principle.
You come to the lab, but you don't come to the lab. So it's self-selected, the group.
Yeah.
But yeah, so come to the lab.
Yes. Right. As for whether or not it makes my microscope skills, like less developed, I've used microscopes before, so I think that like maybe it's not so relevant. Like now, like I'm sure that at some point in my career, if I wanted to learn how to use a microscope, I would. Maybe like similar to what people were saying earlier, that people who are interested will learn, and then people who aren't won't. Yeah. So then
Options
it gives
exist.
the option.
Well, and if you have a offline curriculum that you can get to quickly, then when you need it the night before, you could study up. So some of these skills are rarely used. We can, have on-demand training.
That's a good point. And then my question was, in general, what is the timeline, like specifically for Cornell, for implementing some of these like curriculum changes? Like, will it be in the terms of like, within the next 5 years, 10 years? Just curious, since like we're just starting out in medical school, like will these be things we see before we graduate, or will it be something that like once we graduate will help implement?
TBD.
TBD.
TBD. Working on it right now.
It's going to be a continuous No,
Yeah.
it's gonna be something at this year, something at the next year,
Yeah.
something at the
It's
the
gonna
year
be-
after. No.
Yeah, it's gonna be like a series of pilot studies. Like I can say for the simulation course that you'll do at the end of medical school, transition to residency, that was in process for I think 2 years. What like 1.5 to 2 years, I think, before we ran like the full class through it. Like we had a pilot year, and then we did another year where we had most of the class had to take it, but not all because of like MD PhDs coming back and like matriculation issues, things like that. And then last year was the first year that we had basically the entire class ran through it, and I think we had 95 students. So it's just been kind of like we had 31 year, then 56, 58, and now 95. And so now it's like, all right, this is a standard established part of the curriculum, but it does unfortunately kind of move in somewhat fits and starts, but also it's just a very graded implementation of something. So hopefully, like if we're gonna, I'll say this, if we're gonna do something cool with VR, or if we're gonna implement some sort of simulation technology, we will be sure to let you know. Like the messaging will be really important.
You want to see it in your time, right? Or not?
That'd be cool.
Yeah, right. And that's great. Having that enthusiasm is fantastic. That energizes us. Like, all right.
Are you an MD or MD PhD?
MD.
MD. All right.
Both MD.
Both MD. All right.
7 years.
Yeah. You're only giving me 4. Jeez.
I know Chris had a comment, and then I wanted to say, I feel like the discussion is really useful. So I'm not going to force everybody to break into groups. But I did want to get the opportunity to hear from the valuable resources that serve as competition. And maybe after this comment, it would be nice to hear your comments on what do we think of outcome measures that would be useful for us.
Yeah, I'm just curious about the kind of modalities for their pilot and how you see things emerging from a training standpoint. I mean, are you running these as guided experiences with other, the attendees in the headset as well, or are they kind of one by one? Are you having participants watching the experience of the student in there? Do you envision there to be kind of just like the online video case, kind of take-home headsets that students can review on their own time?
That's something that we're still trying to work out right now. I think one thing I want to keep clear for it is that seeing VR as a form of simulation, I think a debrief after any sort of simulation event, be it mannequin or SP or VR based, is going to be really crucial. Like certainly we want to have a curriculum or something that they go through, but I think having the students be able to talk about it, kind of like what we are now, like have that discussion that can really stimulate it. In my experience, if you have just a few students who, in a small group have really engaged with the topic, it can just bring everybody up, kind of the rising tide lifts all boats thing. In terms of the actual specifics of how to implement that, we're still working on that.
I guess
So, well, I asked Katja to talk a little bit about more how we could think about validating these experiences. But before I do that, I don't want to cut the conversation off. Were there other questions in this along this vein? So I think this is an opportunity. We have 15 more minutes before we're going to go on to feed everyone and then go on to the afternoon's workshops. So I think this is a particularly good opportunity to think about your particular projects that you may have in mind and what questions you might want to ask about how to validate outcomes, and particularly in the context of the different funding mechanisms that you'd be looking at.
So I guess one of the things that we always think about is how to fund our studies, or how to gather funds to implement programs that we feel are useful, right? So as a biostatistician, I have to tell you that it's very important to get the right study design for the right stage of the project. I don't think this is anything new, but I would say that oftentimes we get projects that are too big or too small for the stage. So I'm curious actually to hear how you guys are validating, whether you are thinking about validating, and what sort of study designs have you ever considered? Is it something that you're doing or not doing at all?
I have a
Mhm.
question about like would you? I'm sorry. Thank you. I wasn't like gesturing for the mic. Sorry. Would you always counterbalance within subject or between subject? Because I feel like the exposure order, if you were comparing virtual to a non-virtual intervention or educational design, I think it's a classic experimental question. But if it's the same, it's the same educational module. How do you do that? What's the best way to do that?
Right. So I think it's a very complex question, and it really depends very much on your question, on your research question, right? So that's one. And second, I would say it's also a feasibility question in a way. Sometimes we want to do a randomized order, but we just can't because there is a learning process going on. Sometimes it's just a limitation of the setting, and there's also a question about statistical power, right? So if you're looking to do a feasibility study to see, let's say, how virtual reality module works within person, order, whatever it is, you can actually get a few subjects and then manipulate the intervention within person. And I'll tell you something else, which is relatively new, which comes from educational research, which is that, I'm not sure if you guys are familiar with that, but there's a lot of single subject study designs in education, and it has been around for a long, long time. We don't see this that much in clinical research in psychiatry, for example. However, recently, about a year ago, there was a new conference at NYU where biostatisticians came together and actually started talking about the value of single subject designs. There are also methods that actually pull those data from single subject designs into meta-analysis. So this is to say that there are new methodologies being developed or rediscovered to answer questions like you have. There's no one answer to your question, but I would just say that speak to the biostatistician who is well-versed in the new methodologies to see what is the best approach for your research question. And then if you have feasibility data and you want to just do a randomized study to sort of get at efficacy of whatever it is, then you might move to the between subject designs. But this is not set in stone. I would just say that really to summarize that there are so many new methodologies being developed, and particularly given how much data we have, the machine learning approaches as well. So don't think about ANOVA anymore, but look at those state-of-the-art methodologies.
Do you feel like different funding agencies might have different opinions of study design on a very practical level? Do you feel like there's a difference between applying to a family foundation and like, what is a single subject thing, or perhaps the other way around?
I think it's absolutely true. I work mostly with DoD funding and NIH funding and some foundation funding, PTSD and psychosis, and it really depends. And I think the last panel was really speaking about this. It really depends who you talk to. At the same time, though, I have to tell you that recently NIH, for example, is catching up with the newest methodology, so they will ask questions that we never heard before. Before, when we proposed a complicated methodology, we will hear, why do you overdo it? Now we hear that they want to hear about the new methodologies, but also what happens these days is that, I'll put it this way, researchers tend to want to do too much in one project and oftentimes just don't get funding because of that. So that's something to think about. So you may want to do a complicated study, but on one or two outcomes versus more than that.
Are there other?
Do you guys have any experience with, maybe let me ask you differently. Have you ever received funding for implementation of educational virtual reality programs? Or is it something that happens internally?
So not in a clinical sense, but yes. But that led me to ask, and if you could comment on funders' interests in replicability or reproducibility, which is something that that is an opportunity working in virtual environments in particular, because we can readily share our stimuli. Do funders are they interested in that yet? I know NIH is from a clinical trial perspective is interested, but could you tell us what you're seeing out there?
So I have never seen any funder coming back and asking about that particular part, but it's being able to reproduce is huge right now. And when we hire biostatisticians, that's one of the requirements of being able to document your work, reproduce, and do everything else that comes with it. What we do see is actually considerations about confidentiality and privacy. It's mostly in clinical work, so I don't know if it's going to spill over to education, but we have to go and explain exactly what's going to happen, particularly if you work with vulnerable populations, children, elderly. So, yeah.
Curious if the audience has experience with, because in an experimental context, FERPA does not apply, but once it goes into an actual educational realm where we're working with our medical students, then it would apply, I assume. Does anybody have any experience in that regard, or would we be building off of what you found in the clinical domain?
I know that the IRB asks if you're going in that route, and then I haven't had to yet go that way. Yeah.
We've done, so I can speak in a tiny sense. So we've done that a little bit. And it's an interesting question of when you can fairly ask people to opt out of having their data shared. So if you're saying, I'm going to teach you something using this modality, then you're not offering the option to learn using that modality. So it's an interesting consent mechanism that I haven't seen before, which is I'm going to do this thing and you will do this task. And then after you've done the task at the end of the semester, I'll ask you if I can keep your data, which is, feels like introduces some interesting problems about dropout that I wonder if you could speak to, or is that sort of, it's like, it's a new problem for everyone, like not a failure to treat, but refusal to tell you whether or not they were treated.
I'm not familiar with this particular aspect, but from statistical perspective, dropout is huge, but so is preference. And I wanted to say something about this, particularly as it applies to virtual reality. So in clinical research, we oftentimes have trouble recruiting patients. And I think people talked about this before. Once you propose that once you tell them there is a virtuality component, and even more so if they have a choice, we get much higher recruitment rates and also retention rates. So it's a little bit different, but and I wanted to mention one other thing, which is that I believe yesterday and today we were talking about interdisciplinary research in this area. And when it comes to that, it's great until it gets to data sharing agreements. So I think it's just worth writing something thoughtful in the proposal about this, because it brings a lot of problems at the beginning and then during the duration of the study.
So that's an important point. Other questions from the audience? Or I feel like we're all sort of participating, so not audience, from the other folks, or from the panel. So I think we have time for one more, and if nobody else asks, then I will ask. And when you talk about preference, if you have any techniques, so broadly, the techniques that people use when you say we're going to recruit using the advertisement that it's a virtual reality treatment, but then you need to put people in the non-virtual reality arm for at least a period of time. So I know that something you can do is say, well, you're going to do it next or you're going to do it second. So to have the crossover aspect, has anyone had experience using other methods of accommodating so you don't have the VR group and the angry group in your experiment?
You know, it's actually interesting. I'm not at the liberty to discuss specific findings because they're under review right now, but it turns out that preference versus outcomes are two different things. So it's not so much that the preference of treatment and then receiving the treatment of your preference is leading to better outcomes, but it likely is leading to better retention, which from the statistical perspective has a huge implication. So that's one thing. And second, there are new randomization methodologies being developed where you actually can incorporate patient preference into the randomization scheme. So it's not that you're asking about preference and then disregarding it and maybe using that in the analysis, but it's actually randomizing based on that. I believe UPenn is developing that methodology. So something to keep in mind as you're thinking about your studies.
Okay. Yes, please.
Something that just came to me, I know with some of the ethics of educational research, and I think it probably applies to clinical situations as well, when you're, as opposed to offering an intervention to one group and then the other group not getting the benefit of that intervention, would be having kind of a first half, second half. Like you either get the intervention first or you get it second. So that might be a way to entice people to stay. Although I guess you would run the risk of, if they had the more interesting intervention in the first half of the study, then they don't stay because they don't want to do the second half.
Right. And you know, there's a bunch of different study designs that can try to address that. Educational research typically happens in clusters, so it's a class or a school or whatever the cluster is. One of the emerging designs is step wedge design. I don't know if you guys are familiar with this, where you actually roll out the intervention in stepwise manner, and you can actually incorporate randomization into the process as well. So I guess I'm going back to the same message, which is that there is a lot of different designs. Speak to the biostatistician really at the beginning of the planning of the study, right? So it doesn't have to be, everyone will get what they need to get. It's just a matter of how do we do that so that we can also evaluate some sort of outcomes that are important.
So early, consult your statistician early and often.
Yeah,
is
I
a
think
conclusion.
Lisa said that at the panel before, but it's really important, particularly that, you know, there's a lot of work, as you well know, a lot of work going into planning of a study or even educational program. And then you may find out that there was a way to optimize it or get some more out of what you're doing.
Thank you. We are coming up on 1, and the only reason that I want to end this is because we have we have the opportunity to ask individual questions if you can tackle people over lunch, and also we have another series of workshops in the afternoon. But I would like to ask, so I am going to pull together some notes from the panel because there were some important resources. If my fellow panelists will oblige me, if you put your name in that, so we did not do the template, but if you put your name and email address in the template, then I will email you the notes that I pulled together from this session. And are there any closing questions from anyone? Yes. So if you look on the website for workshop, if you put in your name and email address, and I will send out the notes that I pulled together from today, because I think there's been some valuable things said. Did you have a comment?
Go right ahead. I'm not gonna go. Just to thank you. Just a quick question for people who are looking for funding for educational research. Are people looking mostly like at NIH, or are people going to the Department of Ed because there may be opportunities there?
Right. I actually don't know funding mechanisms for educational research other than training of, let's say, physicians or teachers. And there are some NIH funding mechanisms for that. I wonder if
Yeah.
Department of Ed they do like single subject design.
I would imagine so.
The Department of Education, the U.S. Department of Education, I work in pediatrics, so the single subject designs have been, in my experience, acceptable there. So not always funded, but, you know, recognized and accepted.
You know, it's actually interesting because those designs have been around for a long time, and then rehabilitation research were using it. And then they realize the value of those, and they're coming back for psychiatry, for example, right? So application psychiatry. So it's kind of like that, but it's more systematic, I would say.
Okay, thank you. So our panelists are all scattered, but I want to thank them.